and there can be a significant amount of missed lesions due to fatigue and inexperience. And when it comes to surgery, let's come to surgery at a little later stage. So deep learning and endoscopy has three basic subclassifications. One is lesion detection. Second is image classification. That is, lesion detection is basically identifying the polyps in the early stage cancers. And image classification is differentiating between malignant and benign tissues. And then quality control. Have I covered the entire area of the esophagus or the stomach in endoscopy? Okay. So let's come to esophageal cancer. So esophageal cancer is the 7th most common cancer globally, and it is the 6th leading cause of cancer-related death. There are two major types of esophageal cancer, and what you see is a endoscopic image of the esophageal cancer. So the two main types are esophageal squamous cell carcinoma and esophageal adenocarcinoma. And esophageal adenocarcinoma is often due to GERD. When I mean GERD, it is, just a second guys, 1 minute. Just give me a minute, please. There has been a hang up. 1 minute.
Yeah, no problem, sir.
Just a second, please. One minute, sir.
Yeah. Take your time, sir. No problem.
Sharing it again. Can you see my screen?
Yeah, it's visible. It's visible.
See what you're seeing over there is a endoscopic image. It's a very interesting image. It's a esophageal cancer. You are seeing that big growth over there. Okay, but 90% of the times it is not very obvious like that. All you see is a red patch. And when I mean a red patch, you can see that the entire esophagus is already looking red. And in that, if you want me to find out another deep shade of red, it is like, like my wife tells me, you don't know how to differentiate between two red shades of lipstick. So it kind of becomes difficult. So that's where, I realize that neural networks of my wife are much more developed than, my neural networks in this particular stage. So that is where deep learning comes into play. So squamous cell carcinoma is essentially the disease of India. We see it in the poor countries. We see it with poor hygiene. We see it with junk food and all that sort of stuff. The esophageal adenocarcinoma. Now this is more common in the West, but it is also now rising in India. And this is mainly due to obesity, GERD. You've heard of GERD, right? Reflex, where you would have felt that heartburn in the stomach. That itself can lead to esophageal cancer. And the rates of esophageal adenocarcinoma are increasing significantly, even in countries like India. But what is happening is that a precursor lesion, there is a precursor lesion, which is a precancerous lesion, and that is called as Barrett's esophagus. Now, if you take a country like India, if you take people who have been trained about 10 years ago, Barrett's esophagus was not very common. Esophageal adenocarcinoma was not very common. And these cases are increasing right now. So if you kind of think about it, a person trained 10 years ago is not have seen a lot of cases of Barrett's esophagus during training, which means that they might miss out cancerous lesions in the patient while doing an endoscopy. Patient has severe GERD reflex. They put an endoscope. They see some lesion. But they don't know whether it is precancerous, cancerous, or normal tissue. And that is purely due to lack of expertise. But at some stages, in many cases, there is going to be a significant amount of difficulty in assessing the images as well. So this is where computer vision comes into play. So to explain computer vision to doctors, the example I give is hearing. A dog is able to hear frequencies, which I don't need to explain it to you engineers, but when I explain it to doctors, the example I give is very simple. A dog is able to hear frequencies which a human ear cannot listen to, but a computer can, the similar way the computer can actually look at things and identify things on a CT scan or on imaging or on endoscopy videos, things which a human eye cannot see. So the big challenges are, by the time the symptom comes, the patient is at an advanced stage of diagnosis, and obviously the standard surveillance protocol are kind of inadequate. And so DLMs have kind of picked up on a significant rate. We have seen multiple number of studies which have been able to differentiate between superficial and advanced lesions. Many of these lesions, if you look at the Kai study, it was a Chinese study in 2020. The deep learning algorithms were able to outperform senior, mid, and junior endoscopists. They were almost equivalent of very senior people, and they outperformed almost most of the endoscopists and endoscopy surgeons in the hospital. And the group study was also quite a landmark study because it was able to do identification of the Barrett's neoplasia, which was considered as kind of very difficult to identify. And the Yuan study was also a landmark study in about 5,900 patients where they actually tested it. They found that the miss rate of the lesions decreased significantly when the endoscopist was assisted by AI. So it's a very simple thing. What you will see over there is the deep learning lesions are marked in blue, and the endoscopists have marked the lesion with a black square. And the area under the curve was always pretty significant, around 0.9, which means that endoscopy has, in the area of endoscopy, AI has a major role to play. You would all heard of H. pylori. H. pylori is an organism. It is a bacteria, and it is an independent risk factor for gastric cancer. And if you go to endoscopists with severe gastritis, they will often do an endoscopy, take a small biopsy, and test for H. pylori, test for the bacteria, and then they will put you on a course of antibiotics for 4 to 6 weeks. But the fact is that to confirm the diagnosis, you need a biopsy. You need to take a chunk of tissue, which means that there is a risk of bleeding. But what currently with AI-related techniques, they have just started entering into the market also. These technologies have been there for about 2 to 3 years. They're entering into the market right now. The aim of developing these technologies is that not just that you're able to identify the ulcer, but you're also able to prevent a potentially painful and a potentially complication-ridden biopsy. Nobody wants it to be, to have a chunk of tissue taken up from their stomach and send it for analysis. If you can use AI-related computer vision techniques, I think people are going to be pretty happy about it. So if you look at the red dots, each of these red dots is the endoscopist prediction of identification of the H. pylori-based ulcer, and the green dot is basically a summation average prediction of the endoscopist. And if you can see, the area under the curve is almost 90%. And this algorithm, the Session-2, it was a Japanese study. This was trained on about 5,236 patients, and it outperformed experienced endoscopists. And if you kind of take a country like Japan, Japan has one of the highest rate of gastric cancers in the world. And on an average, endoscopist performs around 15 to 20 endoscopies a day. An average endoscopy takes around 10 to 15 minutes in an expert hands. But when you reach the 15th endoscopy, if you've done 15 surgeries throughout the day, if you've done 15 endoscopies throughout the day, there is a significant amount of fatigue. And what they found is that even among experienced endoscopists, the user fatigue is decreased significantly. An interesting phenomenon, I was hearing a Japanese endoscopist talk about this a few months ago. And the overall consensus, some of our Indian endoscopists, gastroenterologists were saying, oh, will this mean that, the newer generation of endoscopists are going to be completely, dependent on AI to identify stuff? Will their clinical sense not be enhanced? I thought that was a very valid question. Nobody wants to be treated by an AI algorithm. Everybody wants to be treated by a doctor. I think that's something which we can all agree. Even if I was, I understand AI to a reasonable extent. But even if I was being treated, or if my son or anyone on my family was being treated, I would, want to be treated by a human physician. But the Japanese endoscopist had a very different perspective on this. He said that the training levels of the junior endoscopists is increasing significantly. Because if you kind of take the mid-level or the junior endoscopists, they are not being supervised on every case by an experienced person because the patient load is simply too much in a public healthcare system in Japan. And what he meant was that if an AI is able to teach them, okay, buddy, you have missed this lesion, I think you should perform better. He found that even without AI, the performance of the junior endoscopists is increasing. So that was a very unconventional take on how AI is helping surgeons train. So that was very interesting for us. One more area where AI has kind of taken up significantly, and many of these applications have been commercialized, is colorectal cancer. And the colorectal cancer, the main aim is to identify polyps. Polyps is also called as an adenoma. These are all precursor lesions to colorectal cancer. And colorectal cancer, as many of you know, is one of the most common cancers, high rate of morbidity. In the current state where I'm living, Rajasthan, colorectal cancer rates are pretty high. And what they found is that the adenoma miss rate, that is when a colonoscopy is being performed, the miss rate is around 20 to 30%, which means that 20 to 30% of people could have had a, could have had a colorectal cancer from happening at all. They could have prevented the colorectal cancer from happening completely if they had either an experienced gastroenterologist or if they had had AI. And these high rates, miss rates in this modern era are completely unacceptable. And so all these algorithms are tested with something called as an ADR, which is the adenoma detection rate, which is the key quality metric over here. And they kind of found that if you look at the left one, that was a polyp which was removed by the endoscopist. But the AI algorithm was able to identify additional polyps with early malignancy, and that was very significant. And multiple commercial applications have come up in this particular field. In fact, in India itself, in the Asian Institute of Gastroenterology, Hyderabad, they have started using this on a regular basis at a high volume center. Medtronic has gotten CDSO approval for GI Genius, which is essentially an adenoma detection tool. And this has completely changed the way endoscopies and colonoscopies are being performed. So let's come to deep learning in surgery. So this is where I can speak with a little more conviction, because the previous things which I spoke about, these are not things which I was doing. These are things which I have collected from literature for the sake of this lecture. But here is where what our role comes into play. So deep learning in surgery is still at a very nascent stage, unlike endoscopy. There are multiple different reasons for that. We'll look into it. But what can be the role of it? One is real-time decision support. You are about to enter into a particular plane. You want to know whether it is right or not. You are about to injure a structure, cut a structure. If someone is there to tell you whether that is safe or not. Skill assessment and training. Are you a good surgeon or not? Now, this is personally a very important topic for me. Like I told you, in 2016, when I was assisting as a junior, as a resident in Madras Medical College, I used to see different levels of skills. And for me, it was a very hurtful thing. A lot of surgeons will disagree with me, but a simple question to the audience. Will Indigo or Air India allow a pilot to drive a plane just because he commanded a MiG-21 in 1971 war? Will you allow him to fly fighter jets on Rafale in Operation Sindoor just because in Kargil war he was a great pilot? No, you will not, right? Because pilots undergo regular testing, training, retraining. Their skills are regularly reassessed every few months or every few years. They have to clear certain stages. They have to evolve with technology. And at every point, objective assessment is being done. Unfortunately, not just in India, but all over the world, surgeons are not assessed. We see surgeons, they might have been great surgeons about 20 years ago. Now they have been handed robots, laparoscopy, but their skill sets are variable. But patients go and trust them because they think they are great people. I'm not denying how great they were. But at this point of time, there is no mechanism to test whether they can actually perform the surgery or not. Similarly, it comes to even younger surgeons. Just because, so I finished my MCH in pediatric surgery. On paper, I'm a qualified pediatric surgeon, which means I'm licensed to operate on children. I do operate on children. I operate on neonatal children just born 1 day old. I perform surgeries for congenital anomalies. I do laparoscopic surgeries for pediatric cancer. But a patient comes to me with complete trust. A hospital employs me with complete trust, thinking that I've been trained in a good place. But is there any objective way to assess my skill? If you kind of think about it, there is actually no objective way of assessing it. In our surgery exams, they give us a case. They don't ask us to operate. They ask us questions on how do we manage. They ask us questions on the CT scan. They ask us questions on what will be the decision-making process. No, that is extremely important, the decision-making process in surgery. But the actual surgical testing cannot be done because it is not ethical. You cannot have a live patient being tested during exam, right? So that is one of the areas where we started off our startup with. How do we bring in objectivity into surgery? Surgery, has long been considered as an art. People call it as an art, and I also like to call myself an artist. But it cannot go on for long because I genuinely believe that something as beautiful as surgery, something as important as surgery, something as impactful as surgery should be more of a science than an art. Okay, so skill assessment and training, and workflow optimization. What surgery should be taken up first? Those are all mainly ML algorithms, so not major role of deep learning. And then predictive analysis for outcomes, which is going to be a combination of deep learning and machine learning. Yeah. So in our startup Curium, we developed a core algorithm, a deep learning algorithm, which is capable of performance measurement, segmentation, anatomy identification, and surgical radiology. So one of the earliest areas where we worked on was, I think this has been a major session on medical imaging. So I will not talk too much about imaging part of it. I will restrict myself to intraoperative surgical part of it. But this was one of the big challenges which we were asked to solve by a couple of surgeons. So one of the key problems we wanted to solve was a problem called as ventral hernia. Each time you open the abdomen for any surgery, it can be cancer surgery, it can be cesarean section, it can be gallbladder surgery. There is a certain amount of weakness, which means that there's a 20 to 30% chance that a hernia can occur. A hernia is a weakness in the abdominal wall through which contents can come out. And to reinforce that, you use something called as a mesh. But these hernias can recur, and you might need to reopen the abdomen. If you kind of think about it, identifying the mesh on a CT scan in a recurrent case is considered to be extremely difficult. It's also, you are not supposed to detect the mesh because the mesh is supposed to integrate into human tissue. But if the surgeon knows where the previous mesh was, he can avoid that plane and go into a different plane when placing the next mesh. So this was a truly difficult problem which we wanted to solve. And I wouldn't say we have still solved it completely. We have been able to identify it with around 80 to 85% accuracy. So if you kind of look at it, this is where computer vision comes into play. Now we are able to identify using computer vision algorithms subtle changes in the abdominal wall which help us identify the mesh. So when we gave this particular image to a radiologist, we gave it to 10 radiologists. About 6 out of 10 were able to identify the mesh, 4 were not able to identify the mesh. So this was the mesh identified by our algorithm. So this was a reconstructed image by our hernia adhesion support system, and we were able to identify the mesh. In this image, 7 out of 10 radiologists were able to identify the mesh. 3 of them were not able to identify the mesh. Identification is easy when you give them clinical information, when the surgeon tells them where they were placed. But when you ask them to read the CT scan without any clinical information, they were not able to identify the mesh. And this was what was done by the our algorithm. So we kind of expanded our hernia algorithms to even the volumetric analysis. So hernia basically is a protrusion. So to repair it, you need to push that protrusion back inside, which means that the intra-abdominal pressure increases, the pressure inside the abdomen increases, which means that it can compress the lungs and cause ventilatory problems. When a patient comes to you with a large ventral hernia, again, when I was a resident, we had a patient who shared the same first name as me. His name was Vinayagam. He came with a ventral hernia he had been having for 20 years. His wife said, "Abhi bachcho ki shaadi wagera ho gayi. All your kids are married right now. So please get the surgery done. You have postponed it for too long." He was perfectly fine without the surgery. It was causing him a little bit of distress. Visually, it was affecting him. It was protruding out. It was looking ugly. He had to push it back inside when he was trying to pass tools, all that sort of problems. But when we pushed the hernia back inside, there was significant increase in the intra-abdominal pressure. He could not come out of the ventilator. And after 7 days after surgery, he died. And literally, it felt painful because he had come walking, talking very well. And after undergoing a plain hernia surgery, he died. What could we have done differently? We could have postponed the surgery. We could have optimized his lungs before surgery. We could have used a different surgical technique called as component separation, where we release the layers of the abdomen to make it loose to allow the hernia to come inside if we had known that this would have happened. And that's where this volumetric analysis started happening. We found that when the volume ratios, the ratio of the volume of the sac to the ratio of the volume of the abdomen is greater than 25%, these are all established studies, not my studies. The need for component separation is there. That is, you need to perform these special maneuvers. You can't do the simple normal surgery. If we had known that before, that patient would not have died. And this is common to surgeons all over the world, and patients all over the world. So when we, in our startup, when we started building this product, we went to surgeons. We went to surgeons in the bigger hospitals in Delhi, Chennai, Bangalore, Jaipur. We went to surgeons even in the smaller hospitals. I went to Dosa, I went to Churu. I spoke to surgeons with small 10-bed hospitals. And one of the key things was that, Vinayak, if we had this technology, we could have prevented one death. A surgeon in his career of 20 years might have had one death. He might have need to shift the patient to Jaipur because the patient is not coming out of the ventilator after surgery. And these are all real problems that surgeons face, not just in the US or in the developed countries, but even in countries like India. And that's where we started off this problem with. And one of the other problems we wanted to solve was frailty. So sarcopenia means how frail a person is, that there is a loss of muscle mass and function. We found that current surgical guidelines in cancer surgery are very, rigid guidelines. They say if a patient with the proximal esophageal, upper esophageal cancer comes to you, more than 80 years, he won't survive the surgery. So give palliative radiotherapy. Don't do the surgery. Less than 80 years, you can do the surgery. But era has changed. Nowadays, we see 80-year-olds looking absolutely fit, and we see 60-year-olds looking completely crumpled. Is there an objective way of measuring? Now, there is a way of measuring, and it is called a sarcopenia. It basically measures the muscle mass of the abdominal muscles, or some of the muscles in the abdomen. But radiologists are not regularly doing this because of multitudes of reasons. One, it is kind of very time consuming. Then there is a significant degree of inter-observer variability. So I'll skip this thing. So we trained these models, and we were able to identify the psoas muscle. If you can kind of see that the left psoas and the right psoas. Now there is a significant amount of confusion with the surrounding tissue as well. But with almost an area under the curve of 90%, 0.9, we were able to identify the psoas muscle. And now this has been being not commercially used, being used as an academic purpose at Tata Memorial Hospital. So again, this is the input CT, and you can see the psoas muscle. The ground truth is on the left and the prediction is on the right. The amount of accuracy is striking. So AI is being used in surgery to predict outcomes, to identify structures. Biliary atresia is a problem in children. If you identify it using an ultrasound and certain blood parameters, before the age of 2 months, you can perform a life-saving surgery called Kasai surgery. If not, the child has to go for a liver transplant. Now, AI algorithms which have come from China have been able to, with a 97% sensitivity and a 91% specificity, they have been able to identify biliary atresia just using laboratory parameters and sonography. Pediatric appendicitis. Patient comes to you with abdomen pain. Sometimes in children, you cannot localize the pain. You say appendicitis, it comes in the right lower part of the abdomen. But in children, it's kind of very difficult to identify. AI algorithms on CT scans have been able to identify. More than 8 different studies have been performed, and almost with 90% accuracy, they've been able to identify the pediatric appendicitis. So now this is a study which we have performed in our SMS Medical College at JK Lone Hospital. This is in a public healthcare setting. So the pediatric ureteric orifice, identifying the ureteric orifice where the ureter enters the bladder in a child is kind of considered to be very difficult because the anatomy is distorted. The child would have undergone multiple interventions. And in a study which we are about to publish, we have been able to identify with 87% accuracy, with a good sensitivity and average specificity rate, the ureteric orifice, which means that the amount of trauma a child needs to suffer in cannulating the orifice, because each time you cannulate a missed orifice, it causes trauma in the bladder, irritation, bleeding in the child. We believe that this could mean that even less experienced surgeons will be able to perform a pediatric cystoscopy effectively. So here is one example which I want to show you. So you all know about bariatric surgery. Bariatric surgery is weight loss surgery. People call it the gastric bypass surgery. In it, you measure a certain amount of bowel and you bypass it, the stomach from food from coming, which means that you reduce the absorptive surface of the small intestine, which leads to weight loss. Now the challenge is that if you measure too much, the patient loses excess weight. Okay, and he becomes malnourished. If you bypass too less, the surgery fails because patients don't lose enough weight. So this is how a very famous bariatric surgeon in the US is measuring. This is a publicly available video. He's saying he's actually measuring it. And he's saying that the metal part, now this is 5 centimeters. So each time I measured was approximately 5 centimeters. So when actually surgeons, when we went through literature, we found that surgeons misestimated it by a range of almost 33%. Which means that the real challenge was that even in 2025, in laparoscopy, in normal 2D conventional laparoscopy, there is no way of performing intraoperative measurements. Even in hernia surgery, if you want to measure the size of the mesh, you have to put a scale, actual scale inside and do it. When you're cutting the margins for a cancer, you want to leave a 5 centimeter margin in a bowel cancer, there is no tool to measure the oncological margins. So what we did was something very simple. Now this is a video of a surgery being performed in New Hampshire by one of our key opinion leaders, Dr. Hani Takla. So what we have been able to do is that we have been able to use 2D feed, and using certain computer vision techniques, we have been able to convert it into a 3D feed, to do a depth analysis, point out the Z-axis, and actually measure intraoperative bowel lengths with 90% accuracy. We are trying to improve the accuracy. We are trying to commercialize it. We are working with leading OEMs throughout the world, trying to see if this is going to be in the ORs in the next few years. So this is a demonstration of our intraoperative intelligence where we are identifying the organ. So what that green structure which you see is the gallbladder. If you keep your dissection close to the gallbladder, you don't injure any structure. You come below the green line, there is a good chance. So this part, this part which you see is the duodenum. The common bile duct is over here. So you go over there, you result in that catastrophic injury which I was talking to you about. So essentially what we are trying to do is we are trying to bridge the skill gap. If a surgeon is unable to identify crucial structures, we want to have the surgeon identify it. In this particular case, just for demonstration, it's kind of relatively clear. But I can assure you, when a patient comes to you with acute cholecystitis in severe pain, this is not how clear the anatomy is going to be. So this is me on a laparoscopic trainer. And what we are trying to do is we are trying to measure ambidexterity, how good a surgical performance is. We are trying to trace the path of the surgeon. We are trying to measure whether there is tremor. As you can see, I'm kind of struggling with my left hand. My right hand is better. Surgeons can use this as a feedback to improve their own performance, to improve their skill levels, to identify whether they are performing at an optimum rate, to compare themselves to their peers. And basically, this is what we are doing in my startup. So a key problem which was solved by an Indian who started a startup, like as usually he started this in the US, was how do you estimate blood loss? So every day we perform hundreds of surgeries in our own hospital in Jaipur. In fact, many hundreds of surgeries are being performed across departments. There is a significant amount of blood that is lost. There is a significant amount of blood that is transfused. But the real challenge is, how do you currently estimate the amount of blood loss? Because if you transfuse too much blood, there is a whole lot of problems, immune problems. If you transfuse too less, obviously you are not solving the problem. This becomes an issue essentially in cesarean sections, in normal deliveries. So using spectrophotometry and computer vision, there was a guy, Satish, he started a startup called Gauss Surgicals, created a product called Triton, using a simple iPad, old iPad 2, using a grant from Apple, using a standardized pad. He was able to show the blood-soaked pad in front of the iPad and accurately estimate blood loss. Now, a real challenge, you might say, okay, is this a very difficult problem to solve? But the real challenge is that, it's not just blood. And that's where the principles of spectrophotometry also come into play, because there can be urine mixed with that. There can be normal saline, which we use to wash the tissues, can be mixed with that. There can be bile mixed with that. But it is all, again, able to correctly estimate the hemoglobin loss by looking at the tinge of red using computer vision techniques and accurately estimate blood loss. They were able to do this with 95% accuracy. They sold the startup to Stryker, which is a major OEM, for a very undisclosed sum. But now this is being implemented in the ORs. And currently, I'm working with them to see if this could be implemented in our own defense circles to accurately identify, estimate blood loss in soldiers at the border, so that the correct amount of blood can be transfused even at the forward post. And I do believe that AI is not just artificial intelligence; it is truly augmenting intelligence, and we have a huge potential to change the way clinical problems are solved, and there are a whole lot of problems to be solved. And I genuinely believe that there should be a strong intermixing of the clinical sciences and the technical sciences to actually come and solve the problem. You need doctors who are actually there doing the surgeries, performing procedures. You need them to be interacting with the scientists, the deep learning technicians. Only then real progress can happen. Thank you so much. I'm open to questions. I would like to, yeah.
Yeah, thank you so much, sir. The talk was truly inspiring. I hope, as you already mentioned, that we need doctors, right? Because without data, we can't do anything. Although we have a lot of deep learning models, okay, that is fine.
In fact, I was just listening to the previous session. I think the real when we talk to other startup entrepreneurs, when we talk to tech people, one of the key problems is that they are not able to find clinicians to handle data. In fact, my area of expertise is how do I process surgical data and convert it? How do we bring in supervised learning, unsupervised learning to actually annotate the clinical data which we have? And I think that has been the big problem. That's why ML algorithms have progressed significantly. But when you're talking about actual computer vision, there is a significant gap. Yeah.
Yeah. So probably, participants might have not even. I don't know whether they have interacted with any doctor speaking about AI. Being a doctor speaking about AI, the importance of AI and its role in surgery, its roles in detecting cancers and all, right? So this is a really, nice forum to discuss. To interact with the doctors like you, and so that at least the kind of work which we are solving is whether we are going in the right direction or not. The only problem is what we are facing is, yes, there are data sets available. We are just applying the data and getting some quantitative results, and that's it. I think that's not the end, which you have already mentioned, right? Ultimately, it has to be deployed somewhere, like you people are doing. So, definitely, I hope the participants will learn so many things from you, at least, because being a doctor, having your own company, and where you are again using or implementing AI algorithms, it's really wonderful to see all these things.
Yeah, so we have a couple of doubts. I think Dipankar Das sir has asked what ways AI can help in real-time decision making, how to safely integrate it. Now, this is a big challenge, to be honest. The real challenge when we have is that how do we bring in higher volume computing power into the operation theater, and it is expensive. So right now we are trying to integrate our. There are multiple steps. Okay, one of the big challenges when we are developing medical technologies is it is costly. It is costly to develop it. It's costly to I have to pay my engineers. I have to pay my scientists in my startup. I have to pay the people who are annotating the data. It is expensive. Second cost is obviously the computing power is also expensive. I think when you're working as a startup, getting your GPUs, applying for grants, it's a big challenge. I think people know that it's a big challenge. So the other challenge is obviously going through regulations. When you're having a startup, say, I think the biggest challenge is bringing translational. You build the technology, you build this thing. How do you get the approvals? In a clinical study, for academic purpose, I can say that it is 90% accurate. But when I need to bring it to the actual OR, when a surgeon is going to take a decision based on it, 90% accuracy is not enough. When you see that big, nice area under the curve, 0.09, it looks very great. But you need it to be almost 100% perfect, near perfect, when you're bringing it to the OR, because you don't have, the margin of error when a surgeon is taking the decision is very less. For diagnosis, it is okay, but when a surgeon is going to take a decision and cut something based on that, there you are entering into a gray territory. Obviously, there is ethical issues of consent. Is the patient consenting to that technology being there? It's kind of easier to develop these things in India right now. It's expensive to develop. Funding in India is difficult. Deep tech funding is almost non-existent in India when it comes to private equity. They don't understand it. They will ask you what is the return of investment, the venture capital. But It is kind of easier implementing because the regulations are currently less. But that's also a disadvantage to patients, because we foresee that if unless regulations are brought in for patient consent properly, they are also going to be at risk when AI technologies are going to be used. So it is a double-edged sword. So yes, I think Bhaita has asked, what is the potential risk of relying too much on AI? No, I don't think you should rely too much on AI. I don't think you should rely on ChatGPT at its current form, at least. There are specific AI-related tools, but they need to be validated on a larger populations. So there are a lot of ML tools which are being used currently now. Certain old scores. So I'm writing a review for another paper on liver transplant. So we use a score called MELD. Now that is being currently replaced by ML-based algorithms. But these ML-based algorithms have been validated on a large number of patients, both retrospectively and prospectively, before they are released to the public. So unless they are validated, you should not be using it. But there is also a risk if you're not using it. When your algorithm has been proven to be effective, the CHALF score, there's an algorithm, ML-based algorithm, which has been proven to be more effective than the conventional MELD. It saves lives. When you are being resistant to AI and saying that I'm not going to use it, that is also risky, because that means that despite having knowledge in your hands, you're not using it, and that is harming your patient. Which means that the real problem, I'll tell you the real problem with our field, with my field, is that each decision you make, right or wrong, has a potential to impact lives. People die. People actually die when you decide. Either it can be an error of omission or it can be an error of commission. But people die if you make the wrong decision. So yes, that's there. So from a 2D image, how can we predict how much blood is consumed? So they were using spectrophotometry. They had trained a large number of images on computer vision tools. I really don't know the basic algorithm what they were using. It's all under patent right now. It's owned by Stryker. But they had trained by using gold standard. They had created a specific size of gauze pad, abdomen pad. They had used actual blood to stain the pads using gold standards, and then they had used it, trained it using done a spectrophotometric analysis, and then fed the data to the algorithm. So using that data, that trained data, they created this Triton tool, which was able to identify with almost 95% accuracy. So what consideration must be made when deploying AI in lower source or rural surgical settings? I genuinely feel that, I mean, the most important consideration is obviously the cost. So to put that AI algorithm, so that measurement tool, it's a simple tool. People have been trying to do that for many years, but we have done with a reasonable amount of accuracy. We are doing our deployments right now. Each of the edge device which you need to install in the OR costs us around $1,500 to $2,000. So now imagine, I mean, that's like the cost is the biggest challenge when it comes to employing it in a rural surgical settings. But I genuinely believe as the algorithms become more efficient, they can shift from a GPU to a CPU based systems. Number one. Number two, when the cost of these computing decreases significantly, either with government support or generally as the market forces will prevail, I believe that rural settings can be distinct. So many of these things can be employed in the rural settings. Rural settings we don't have. So if you go to 80 kilometers from Jaipur, we have about 100 urologists in Jaipur. 100 kilometers there, in one full district, there'll be one urologist who cannot handle the load, which means that general surgeons are also doing urological work, which means that they cannot identify the ureteric orifice or identify certain structures on a cystoscopy with good amount of efficacy. And I genuinely believe that AI. See, one mistake which we made when we were starting out, we discarded a lot of ideas because we spoke to key opinion leaders, we spoke to great surgeons, and they said, no, I can identify it, not useful. But then we realized you should not talk to them. You should talk to the person who cannot solve the problem. You should speak to the person who has just graduated, who has finished his training. You should speak to the surgeon in a trust hospital in Northeast, who is doing about 100 cases in a missionary hospital, who wants to treat patients, but he's unable to because he does not lack certain equipment or expertise. And he will tell you the real problem statement. If you talk to the big people, for them almost every problem is solved with technology. Okay, if you want to identify the ureter using, we are trying to identify the ureter in hysterectomy, because hysterectomy is a very common surgery, uterus removal, and you can injure the ureter. But if you talk to a guy in a top hospital in Jaipur, you talk to a person in Manipal, they have infrared labeled stents. They can use it. It's just 20,000 rupees. They say, oh, I use it for my surgeries. but I cannot use that 20,000 rupee stents in Churu. So there is a big unmet need in the rural areas. There is a big unmet need in this thing, and I strongly believe that a lot of this can actually eliminate hardware. So that gallbladder identification is now being currently done by ICG. You actually inject the ICG dye, indocyanine green dye, and do it, which is expensive. You need 4K ICG cameras, which is 1 crore system. You need that dye. 3 months ago, there was a shortage of ICG. Each time you use the ICG, it's 10,000 rupees. So I genuinely believe that software can eliminate the need for hardware. And that's where the cost reduction is also going to happen. So can we determine, can the time of contact of blood can also be a factor? Yes, but I mean, yes, it does make a difference, but kind of, so it is based on, in simple language, it is based on how red the tissue is. You know, the time of contact is impacting it, the change of color of red also changes. So to get into specific, I can share with you the papers which the Triton team has published. I think you can have a look at it. You will be able to understand it even better than me, to be honest. You guys are experts in physics. So yeah, how reliable are AI models compared to traditional diagnostic methods in detecting muscle degeneration? See, currently we are using AI, like we told, that sarcopenia, we are using that as a method to reduce the amount of time taken for the radiologist to do it. The human radiologist is still the gold standard for that. There is no question of replacing them, but the time taken for a radiologist to calculate is also 10 to 15 minutes. If you're talking about a place like SMS, where a surgeon has to interpret 40 CT scans, he's not going to take 10 minutes just to interpret that muscle degeneration. He would rather focus on where the cancer is, identifying where the cancer is invading the vessel. So the main work is still done by the radiologist. He's identifying the cancer and this thing. Now, this is an adjunct which will help in determining what kind of therapy can be done for the cancer. Will the patient be able to survive a 5-hour surgery or not? That frailty, that muscle degeneration. Okay. You see our political leaders, they're all 80, 85. They're all working really fit. Would you deny them major surgery saying that you're too old? But we see 50-year-olds in our own home. They're 60-year-olds in our own, in our own work settings who are walking like they're 80 years old. No, these people may not survive an 8-hour surgery. So that's where we are using AI to determine it. Right now, radiologists don't have the time to do this. So essentially, we are making the process more efficient. We are not replacing the radiologists. We are making their life much better. So how prepared is India's regulatory system, CDSO, to evaluate? No, it's not. In fact, we do have large gaps. I would say even FDA is not prepared. Even FDA is trying to understand. But one good thing was which came out of the entire COVID pandemic was that the people started. COVID meant that a lot of AI related tools. Again, we had a large number of CT scans being performed. People needed to give the CORAD score. People needed to identify whether it's COVID or TB or lung cancer. And you need to do that in like 5 minutes per CT scan, because each radiologist was handling 100 CT scans a day during COVID. You know, that was the kind of load they were dealing with, which meant that a lot of these agencies started giving faster approvals for these products, which meant that there was a lot of funds which were available for these tools, and which kind of, gave a big shot in the arm to the entire medical imaging AI industry. So people say that, it is the entire industry is saturated and all that sort of stuff. I would kind of disagree. We have just scratched the surface. An entire iceberg is waiting, and there's a lot more to do. If someone tells you that this medical imaging AI is saturated, I would say they are being stupid, because they have not kind of understood the problem. What's really happening is that if a new problem comes up, the end 3-4 startups come to solve the same problem. So it appears to be saturated. But there are a whole lot of problems which are yet to be solved. So to medical imaging like DEXA, yes, you can use DEXA for that also. You can use DEXA scans for also monitoring sarcopenia. Yeah.
Yeah. I have one.
Yes, sir. Sorry.
I have one. Common query. Let's say maybe this is a question from everyone. Let's say we are working on polyp segmentation, right? And we have developed something. It is giving really good results on some data sets. We have also validated the model on some new data sets collected from new demographic regions. So, are you going to accept this model? On what basis it is going to be accepted in a clinical setting? What you will look at?
Yeah, I think if you're able to perform better than a radiologist or better than an endoscopist, I think you're going to accept that. But the real challenge comes in implementation. How mm, how good it feels and how much less it disrupts the workflow. See, one thing which we have realized when we are using these algorithms is that we all, I'm a man of, I develop, see, 9 to 4, I am in the hospital, I operate. 5 to 12, I am working on my startup. Okay, but I've been trained in RJ or SM in I think if many of you are from Jaipur, I've been trained in SMS Medical College, Jaipur. I performed hundreds of these congenital anomaly surgeries, and I follow a set pattern, a set rhythm. When the patient comes in, I know what to do, what next to do. The sister also knows. That's the advantage of working in a high volume institute. The sister also knows what to do. They give you the right instrument. So I work at a subcerebral level, which means that any disruption in my workflow, it affects my thinking process. So when it comes to implementation, how less you are able to disrupt, how less is the time lag. That's where the computing power comes into play. Basically, if it's going to take 2 seconds, 2 seconds is a very long time. I'll tell you, surgeons are the most egoistic people you will deal with. I think you might have, if you've dealt with doctors, you will realize that they are very egoistic people. I deal with them on a daily basis. Okay, you give them 2 seconds extra, they have to wait. They will create a tantrum. They are like spoiled kids. Okay, so it has to be the time lag has to be extremely less, and you have to assuage their ego. And when it comes to India, the biggest challenge is that they will not accept something which is, it has to come from abroad. Some Ferengi guy has to say it works well. Only then they kind of accept it. That's also, major challenges which we also face. Indian companies have started talking to us. Indian OEMs have started talking to us after the US OEMs have started talking. We wanted to talk to the Indian OEMs first. They were very resistant. India, nobody will accept it. So there is a lot of mental gap for clinicians to accept AI. But I genuinely believe that in the next 5 years, that gap is going to change. And again, it depends on the KOLs you are bringing in, the key opinion leaders, because surgeons are also influenced by people in their surroundings. Some great endoscopist tells that this is absolutely wonderful. It is getting adopted. See, Asian Institute of Gastroenterology, Hyderabad, they started adopting AI algorithms. Those algorithms have been approved in India even before they started adopting. But once the day they started adopting, centers all over India have started adopting it. GI Genius of Medtronic. So it really, but again, there is a big, if you're thinking of commercializing it, Dr. Deepak, simply put, those solutions are expensive. Those are thousands of dollars. Same polyp detection algorithms. And people have started adopting it, which means that if you can reduce the cost, there's an entire big market. 98% of the market is still underserved. There's a big market which can use that. Why do they need to use Medtronic? They can use Dr. Nayak's algorithm.
Yeah.
So, so what type of statistical tests for publications to compare AI model? See, in deep learning, we use what? IOU, dice coefficient, essentially how much it correlates with the gold standard. So if you had seen my, if you had seen the sarcopenia algorithm, I showed you the ground truth, which was marked by the radiologist, and then the model prediction. The degree of overlap can be used by, dice coefficient, intersection over union. So standard computer vision deep learning techniques, you can validate it. Yeah. So in certain scenarios of brain surgery, patients are asked to perform a task so that patient can determine the brain activity. To be honest, I have not thought about it. I'm not a brain surgeon. But what they are essentially trying to find out is that when they're asking them to perform a task, say, for example, when they're removing a tumor from the brain, they want to remove the tumor with least amount of damage to the brain. Okay, which means that when you are looking at it with naked eyes, the brain with the naked eyes, the areas of the brain are not very clearly visible. Okay, but people are actually trying to solve this problem. I'll tell you how. You basically map out the areas using a real-time MRI. You ask them to perform the tasks and see using contrast enhanced MRIs which area of the brain lights up using certain dye studies during a real-time MRI. Map it in an MRI and use certain techniques to project it in real time. A Korean startup is actually trying to do that. Accuracy rates are still, are not so acceptable, but I do believe that this problem is going to be solved. So, say for example, there is area 41 or 40, whatever area is there. Now this is the area for speech. So when the surgery is being performed, awake brain surgery, he will ask you to speak certain words and check if that area of the brain is working or not. Okay, but awake brain surgery is also not easy. The patient should cooperate, traumatic. Now I can eliminate it very clearly if during the surgery I can map the area of 41 and mark it and say I will be clear of it. So AI is playing a role in it. I have seen some early publications in it, but I truly am not an expert in that particular area to comment in depth about it. In fact, I might be so unaware that area 41 for speech also I might be wrong. It might be area 44. So yeah, So any other queries? I think we are also out of time. I think thank you so much. I think I had a good time interacting with you all because most of my interaction is with surgeons. So most of my speech, I had to change my talk significantly from what my surgical audience was, because for my surgical audience, I have to start with what is artificial intelligence, what is ML, DL, what does a convolutional neural network mean. But here I had to explain what endoscopy was. So, for me, I was more anxious doing this talk with you guys because, you are all experts. And I sometimes, I feel like an imposter coming and talking, this stuff in front of you guys. You guys are the actual people solving the problems. I'm just a clinician who is pointing out what is the problem, and you guys are the people who are actually solving it. So I do believe that cooperation is necessary. And with that note, I would like to thank you all. And also wish to make it known that my department here in Jaipur, I will be leaving this place. I'll be going back to Chennai. But if any of the departments want to collaborate, we do have people in our department who are actually willing to collaborate, willing to solve problems. There are a lot of problems to be solved, and we hope to work with you all. Thank you so much.
Yeah, thank you, Dr. Vinayak, for sharing your expertise with us, giving us a lot of directions of research, and also have mentioned that this medical image analysis domain is still alive. I mean, there are a lot of problems to be solved, right? So people are thinking, deploying one algorithm on a particular data set, and let's say they've got 100% or 99% result, they said that their work is over. So it's not like that, you have mentioned rightly. So participants have learned a lot of things from your lecture. There are a lot of takeaways actually from your lecture. So we're really happy for that. So thank you once again, sir, for joining us. And we look forward to collaborate with you very soon, sir. Thank you so much. Thank you, sir.
Thank you, sir.
Yeah, so participants, we have our next session at 6:20. So after 10 minutes, we can have a 10 minutes of break, and then Dr. Agya Pal from Monash University will be sharing with us, and he'll be talking on a very important topic, right? Beyond like full supervision, right? So if all the data are not labeled, let's say for example, you have some labeled image, you have some unlabeled image, so how to proceed with that? So very interesting topic, right? And this lecture was also truly inspiring for all of us, right? So that's why we have intentionally kept some of the lectures by the clinicians who will also speak about the importance of AI. So then only we can feel that yes, whatever we are doing is absolutely right, but there is something which is which still needs to be done, like the deployment phase, right? We all only used to publish the papers, but we are not thinking about its practical applicabilities. So we should also think in that directions. That's what we have learned from this lecture. Thank you so much, and we'll again join on 10.